There is a man sitting in a doctor's office right now. He just got his test results back. The nurse is smiling, the doctor is nodding. The number looks good. It's well within the normal range. He buttons his shirt, shakes hands, walks out into the afternoon, and feels the particular lightness that only comes when you've been told you're fine. He is not fine. And the number that told him he was, that small, clean, completely ordinary number, told him the truth. That's what makes this so hard to accept. The test didn't lie, it just didn't tell the whole story. And in medicine, a half-told story can cost a man everything. What I'm going to walk you through today is one of the most widely used medical tests in the world. A test that has saved real lives and missed real cancers, sometimes in the same week, in the same clinic, in men with nearly identical results. A test that has been debated, revised, defended, and criticized for over 3 decades, and still remains the first thing most doctors reach for when it comes to one of the most common cancers in men. This is about the PSA test. And by the time we're done, you're going to understand it in a way that most people, including, honestly, a lot of people who've already had it done, simply don't. If this is your first time here, I'm Dr. Victoria Reed, and this channel exists for exactly these kinds of conversations. Hit subscribe if you want more of them. Now let's get into it. PSA. 3 letters that have appeared on millions of lab reports, been circled by millions of doctors, and been handed to millions of men who nodded and moved on without fully understanding what they were holding. PSA stands for prostate-specific antigen, and the first thing you need to know, the thing that changes how everything else lands, is what that name is quietly getting wrong. Prostate-specific sounds like it means the test is specific to prostate cancer. It doesn't. PSA is simply a protein that the prostate gland produces naturally, constantly, in all men. It's not an alarm signal. It's not a distress flare. It's just a biological substance your prostate makes as part of its normal function, and small amounts of it leak into the bloodstream all the time. Measuring it is like measuring the exhaust from an engine. The exhaust is always there. But a sudden increase might mean something is wrong, or it might just mean the engine is running harder than usual for reasons that have nothing to do with damage. The prostate itself is a small gland, roughly the size of a walnut, sitting just below the bladder. Its job is to produce fluid that nourishes and transports sperm. Most men never think about it much until something goes wrong, and the PSA test was designed to give doctors an early warning before something wrong became visible, painful, or too late to treat. When the test was developed in the 1980s and became widely used in the early 1990s, the logic felt almost elegant in its simplicity. Cancer disturbs the prostate. A disturbed prostate leaks more PSA. Measure the PSA, find the disturbance early. It seemed like a clean, scalable solution to a genuinely deadly problem. Prostate cancer kills. Catching it early saves lives. A blood test that could do that from a routine clinic visit, that was worth having. And it did save lives. That part is real and it matters. But the story of what the test couldn't do, wouldn't catch, and quietly got wrong, that story took years to fully surface. And it starts with a number. 4. Specifically, 4.0 nanograms of PSA per milliliter of blood. That became the threshold, the standard cutoff. Below 4.0, you're in the normal range. Above 4.0, something may need investigating. That line was drawn, built into guidelines, printed onto lab reports, and used to make decisions for millions of men around the world. And here is where everything starts to get complicated. Researchers began noticing something that didn't fit the clean narrative. Men with PSA levels clearly below 4.0, men who, by the established rules, were fine, were being diagnosed with prostate cancer. Not in small numbers, not as statistical noise, in significant, troubling, consistent numbers. The most important evidence on this came from a landmark study called the Prostate Cancer Prevention Trial. It was one of the largest prostate cancer studies ever conducted in the United States, following nearly 19,000 men over years of careful observation. And what it found reshaped the conversation permanently. Among the men in that trial who had PSA levels below 4.0, the supposedly safe zone, prostate cancer was detected on biopsy in a substantial percentage. Some of those cancers were low-grade, slow-moving, but not all of them. Some were high-grade, Gleason score 7 and above, the kind of cancer that doesn't wait, that spreads, that kills if not caught. These were men who had received normal PSA readings, men who had every reason to walk out of their appointments feeling reassured, men who had cancers that the test's own threshold had quietly voted to leave undiscovered. The researchers put it plainly: there is no PSA level below which the risk of prostate cancer is 0. Let that sit for a moment. There is no PSA level, not 3.5, not 2.0, not 1.0, that absolutely rules out prostate cancer. The threshold of 4.0 was never a guarantee. It was a probability estimate, a population-level statistical tool. And population-level tools, by their nature, are not built to protect every individual within the population. They're built to catch the most, miss the fewest, and accept that some will fall through the cracks. The question is whether the men in those cracks were ever told that the cracks existed. Now here's the deeper problem underneath that one. And this is the part that reframes the entire test. PSA is not a cancer detector. That phrase is worth repeating. PSA is not a cancer detector. It never was. What it detects is disruption, any disruption, to the prostate. Cancer is one cause of disruption, but it is far from the only one. BPH, benign prostatic hyperplasia, which is simply an enlarged prostate, raises PSA. It's not cancer. It's extraordinarily common, affecting the majority of men by the time they reach their 60s and 70s. It is, by itself, not dangerous, but it causes PSA to rise. So does prostatitis, inflammation or infection of the prostate. So does a procedure called a cystoscopy. So does vigorous physical pressure on the perineum, long-distance cycling, for instance, or horseback riding. And sexual activity within the 48 hours before a blood draw can temporarily elevate PSA as well. This means the number your doctor shows you isn't just a cancer signal. It's a composite signal, the prostate's response to everything that's been disturbing it, stressful to it, or simply characteristic of its size and age. Cancer is woven into that signal potentially, but it is not separable from the noise by simply reading the number on the page. A man can have a PSA of 6.0 because of an enlarged, completely benign prostate he's had for years. Another man can have a PSA of 3.1 because a small, aggressive cancer is growing in a small, otherwise quiet prostate that doesn't produce much baseline PSA. The first man might spend months going through unnecessary anxiety, further testing, a biopsy, only to be told there is no cancer. The second man might be told he's well within the normal range and sent home. The test doesn't know the difference. That's the problem. And it's a problem the medical world has been working on, quietly, and not always publicly, for years. So if the raw number isn't enough on its own, what else do we look at? This is where the science gets genuinely sophisticated, and where most standard appointments still don't go. The first concept is PSA density. It sounds technical, but the idea is straightforward. PSA density is calculated by dividing your PSA level by the volume of your prostate. Why does this matter? Because a larger prostate naturally produces more PSA. That's not a cancer signal, it's just physics. More gland, more protein. So a PSA of 5.0 in a man with a very large prostate might have a low density, meaning the number is explained by the size of the organ, not by something abnormal happening inside it. But a PSA of 3.0 in a man with a small prostate might have a high density, meaning the prostate is producing more PSA than its size alone would account for. That extra production needs explaining. APS. A density above 0.15 is generally considered a point where further investigation becomes more justified. Below that, the elevated PSA is more likely to be explained by the prostate's natural size. This one calculation takes a number that seemed simple and reveals that it carries almost no meaning without knowing the size of the gland it came from. And yet, the volume of the prostate is not always measured. The density is not always calculated. The appointment ends with the raw number, and the context it needs to be properly understood stays off the page. The second concept is PSA velocity. And this one is perhaps the most intuitive of all once you hear it explained, and the most unsettling once you understand its implications. PSA velocity is the rate at which your PSA level changes over time. It's not about where the number is, it's about where it's going and how fast. Think about it this way. A man whose PSA has been steady at 3.2 for 5 consecutive years is telling a very different biological story from a man whose PSA was 1.43 years ago, 2.12 years ago, and 3.0 last year. Both men are currently in the normal range. Both would receive the same reassuring response if the only thing measured was today's number. But one of them has a prostate that has been stable and quiet for years. The other has a prostate that has been progressively, consistently, rapidly producing more and more PSA. That rising trajectory is itself a signal. A PSA velocity of more than 0.75 nanograms per milliliter per year has been associated in studies with a higher likelihood of finding clinically significant prostate cancer, even when the absolute level remains below 4.0. The number on its own is a photograph. PSA velocity is the film. One is a frozen moment, the other shows you the direction something is moving. And in medicine, direction often matters more than position. This is why single-point PSA testing, getting one result at one moment in time and reading it in isolation, misses so much of what the test is actually capable of telling you. The power is in the pattern. The meaning is in the change. But capturing that requires testing over time, keeping records, drawing the line across multiple data points and asking, which way is this going? Most men don't know this. Most appointments don't go here. And that is a gap, a real, consequential, completely correctable gap between what the science now understands and what the average clinic visit still delivers. So what do you do with all of this? What does it look like in practice to actually use this knowledge? It looks like a different kind of appointment, a different kind of conversation. One where you don't walk in, get the number, nod, and leave. One where you arrive with specific questions, the kind that turn a data point into a picture. Ask your doctor what your PSA level is, and then ask immediately, how does that compare to last time? And the time before that? If you've never had the test before, establish that this is the beginning of a baseline, and commit to tracking it over time. Ask about your PSA density, which requires knowing the volume of your prostate, which can be estimated or measured by imaging. Ask whether your rate of change over time, your velocity, suggests anything worth monitoring more closely. Ask about your risk factors. African American men have a meaningfully higher lifetime risk of prostate cancer and are more likely to be diagnosed at younger ages and at more advanced stages. If you are in this group, or if you have a first-degree relative, a father, a brother, who was diagnosed with prostate cancer, your risk profile is different from the population average, and the thresholds built from average population data may not be the right lens through which to read your results. Ask your doctor whether the standard cutoffs apply to you, or whether your individual context warrants a more cautious interpretation. These are not aggressive questions. They are not paranoid questions. They are the questions that the science has been asking for years, answered in published research, and waiting to be brought into the room by the person they matter most to. And if you do end up in a situation where your PSA is elevated, where something warrants further investigation, there are now tools available that go significantly beyond the basic test. And knowing they exist can be the difference between an appropriately targeted workup and a blunt, anxiety-producing process that may or may not be necessary. One of these is the Prostate Health Index, known as PHI. Rather than measuring total PSA alone, PHI incorporates 3 different forms of PSA: total PSA, free PSA, and a specific subtype called P2 PSA. and combines them into a single calculated score that has been shown to more accurately predict the likelihood of clinically significant prostate cancer than PSA alone. In studies, PHI has outperformed standard PSA testing in distinguishing cancers that need treatment from benign conditions and slow-moving cancers that don't. It reduces the number of unnecessary biopsies. It sharpens the picture. Another is the free-to-total PSA ratio. PSA in the bloodstream exists in two forms. Some is bound to other proteins, and some floats freely. Cancer tends to produce more of the bound form, so a lower percentage of free PSA, a lower ratio, is associated with a higher risk of cancer, even when the total level looks unremarkable. This ratio can add meaningful context to an elevated or borderline reading, and it's a calculation that can be made from the same blood draw, without additional tests. And then there is the technology that has arguably changed prostate cancer investigation more than any other development in recent years. MRI-guided biopsy. Traditional prostate biopsies were performed blind, a needle inserted into the prostate and samples taken from standardized locations, without real-time visualization of where exactly the suspicious tissue might be. It was statistically comprehensive, but anatomically imprecise. An MRI of the prostate, performed before a biopsy, can identify specific suspicious regions, areas that look structurally abnormal, areas where cancer is more likely to be hiding. A biopsy guided by that imaging can then target those regions directly, rather than sampling randomly and hoping to intersect the cancer. The result is fewer unnecessary biopsies, fewer missed high-grade cancers, and a more honest conversation about what the investigation actually found. It is a more humane process, a more accurate one. And while it is not yet universally available or routinely offered at every clinic, it exists. It is becoming more accessible, and knowing to ask for it can change the nature of a workup entirely. The landscape of prostate cancer detection is genuinely improving. The tools are becoming more refined, more personalized, more capable of telling the difference between the things that need attention and the things that don't. The gap between what was possible 20 years ago and what is possible now is significant, and it is continuing to close. But that improvement lives, largely, in the research literature and in specialist centers. It lives in the evidence base. And for it to reach the man sitting in the exam room, someone in that room has to know to ask for it. That's you. That's the person watching this. The person who now understands what a PSA level actually measures, what it misses, what surrounds it, and what questions need to follow it. Here is what I want to leave you with. There is a particular kind of false safety that is more dangerous than knowing nothing at all. It's the safety that comes from a number that looks right, inside a range that was built for someone else, interpreted without context, handed to you in 30 seconds without the conversation it requires. That kind of safety doesn't protect you. It just makes you feel protected while the thing you're trying to find continues to grow undisturbed. The PSA test is not the villain of this story. It is a real tool with real value that has caught real cancers and extended real lives. The villain, if there is one, is the version of the test that gets treated as a verdict rather than a starting point. The version that ends the conversation instead of beginning it. The version where normal is said with a finality it was never designed to carry. Your PSA level is not your health. It is a signal in a language that requires translation. And the translation requires your age, your prostate size, the arc of that number over time, your racial background, your family history, and the quality of the conversation that follows. Strip any of those away, and what you're left with is a number that tells you something, but not enough. Never quite enough on its own. So the next time you're in that room, and the number comes back, and someone moves to close the folder, don't let the folder close. Ask what it means. Ask what changed. Ask what else there is to know. Because the gap between a number and an understanding is exactly the distance that matters. If this helped you think more clearly about something that affects you or someone you care about, share it. That's genuinely how these conversations reach the people who need them, before it's too late. And if you're not already here with us on Dr. Victoria Reed, subscribe. This is what we do. We go further than the surface. We stay until the picture is actually clear. Take care of the people around you. That's not small. That might be everything.